Thank you very much. I think I'm really indebted that you have called me in such a meeting with full of seats, generally not seen in cardiology meeting, and everybody is interesting and enthusiastic listening. Thank you, sir, for calling me here. And it's a lovely reception which I received here with full heart, and I'm really indebted. I am given a job of discussing device in management of sudden cardiac death, and it's a very broad topic. It's a very broad topic. Why? Because sudden cardiac death is a very important cause of cardiac death in either developed country, underdeveloped country, developing country. So initially it was thought that it is probably a disease of developed country. No, absolutely no. It is a more of disease of developing and underdeveloped countries. The survival out of hospital, I practically say, if I have to ask India, practically no survival out of cardiac arrest. It's a 0%. Even in our hospital, if the cardiac arrest happen in department of hematology or gastroenterology, even I say there is no way you can survive these patients. So we say that it is less than 1%, but I always say it is a 0%. So it's very, very important to talk about sudden cardiac death. This is an epidemiology. We all know that if we have a high risk substrate who has a high risk of sudden cardiac death, but the total number may be small. Total number of sudden cardiac death is mainly in a general population in which no disease is being diagnosed or patient is asymptomatic. This constitutes the majority of the patient of sudden cardiac death. If you have to say what is the risk factors for sudden cardiac death, I think everything is a risk factor. If you are older age, you are a higher risk of sudden cardiac death. If you are a male, diabetic, hypertensive, smoker, obesity, inactivity, dyslipidemia, anything which can lead to coronary artery disease is a risk factor for sudden cardiac death. But what are the risk factors of sudden cardiac death in a population with very high risk? It's a low ejection fraction. Low ejection fraction is the sole important thing in which you can say that these patients have a very high risk of sudden cardiac death, especially and again, channelopathy. If you are a strong family history of sudden cardiac death and some structural heart disease like ARVC, SCM, there are very high risk of sudden cardiac death in certain group of patients. Oh, sorry. This is autocorrect. Channelopathy become homeopathy. It is an autocorrect. I can also, so homeopathy is also a risk factor of sudden cardiac death. Inappropriately given to all patients, in which it has no role. Now we all say the most important cause of sudden cardiac death is tachyarrhythmia. It is not a bradyarrhythmia, mind it. 80% of the death is tachyarrhythmic death, not a bradyarrhythmic death. Now, what I am going to structure my talk. First, who are at risk? That is very important to know. Second, what is the evidence of literature that device therapy prevents sudden cardiac death, improves overall sudden cardiac death in these patients? Third, sudden cardiac death in LV dysfunction post-MI is not uncommon. People say it's uncommon in India, Bangladesh, Sri Lanka. We have a very less sudden cardiac death. Our people are living with post-MI LV dysfunction for a long time. What is the status of device penetration in India? And even I have speculated what will be in Bangladesh also. Why it is important to know who are at risk and what is the magnitude of a problem in a country? Because it's very important. If you can predict it, you can save the life. You can treat it. If you know that this long QT person has a high risk of sudden cardiac death, if you give appropriate therapy, you are going to save the life of the patient. And if you are going to save the life of the patient, the productivity life of a society will increase. A young patient, 45 years old, have an LV dysfunction, you have not given ICD and died, it will not be a good idea. Why it is important? That we have a lot of therapy available. You can counsel a patient, you can give a lot of drugs, you can have a device therapy, and in certain cases, surgery will be helpful in this patient. I am going to focus myself first in ischemic heart disease. Believe me, any patient who has a coronary artery disease in general has a high risk of sudden cardiac death in compared to a general population. In every patient of coronary artery disease, whether it's LV dysfunction, non-LV dysfunction, good optimized medical therapy is mandatory. Revascularization, if needed, and important in an indicated patient, you should not hesitate to give a device therapy because it prevents the sudden cardiac death. This is a typical example, 45 years, a very senior officer in a company. Is practically a CEO of a good company. He has MI 3 years back. His ejection fraction was 30%. He has angio, repeat angio was done, mild CAD. He was absolutely class 1. He was traveling all over the world on optimal medical therapy. One day he has some pre-syncope in the hospital, in the office. Somebody has measured the blood pressure. It come by 100, by 70. They say, no, it may be because of a low blood pressure. He gone to some cardiologist. He advised Holter and see what is the Holter recording. He has a CD during Holter. So people ignore the symptom because they feel we are class 1. We have no symptoms. Why should go for a therapy, something which is implanted in our heart? Low ejection fraction, predictor of sudden cardiac death is known from very long. In 2001, this beautiful article has said there are 4.3% more chance of sudden cardiac death. So low ejection fraction has been known since very long. We all believe that if your ejection fraction is less than 35%, you are symptomatic. 35% risk of sudden cardiac arrest in next 5 years. 35% risk. It is a huge risk. And even in patient post-MI who has an LV dysfunction, ejection fraction is less than 35%, 10 to 15% risk of sudden cardiac death in over 2 years. Whether you treat, if you don't treat, it's very high. If you treat, it reduces by 30 to 40%. Ample trials, no discussion of trials. In a primary prevention, in a secondary prevention, there's ample trials which have shown that device therapy significantly decreases the mortality in these patients up to a tune of 30% reduction. So whether it's a primary prevention or secondary prevention, it's a class 1 indication. And all the guidelines for a secondary prevention, this is a secondary prevention. If you have a CAD patient, you have a documented VT, which is not because of reversible cause. You have no hypokalemia, you have no ischemia, ongoing ischemia. It is not because of reversible cause. It is a class 1 indication to put an ICD. Over and above all the treatment. Now, in a patient who is for a primary prevention, in a patient dilated cardiomyopathy or ischemic cardiomyopathy or post-MI 40 days, it is for primary prevention. Less than 35%, you should have some symptom, class 2 to class 3. But if your ejection fraction is less than 30%, you don't require to have any symptoms. So if your ejection fraction is less than 30%, it's a class 1 indication. Patient may be entirely asymptomatic. It doesn't matter. But literature is enough that it shows that SCD is prevented by giving device therapy. Now, this is very important. We all know. But what is the concern among population? This is a costly therapy. And people say that only on base of ejection fraction, why you are giving? I have no NSVT, my QRS is normal, I have everything, I am class 1. Why you are giving me ICD, a device which is costly? And people also say that there is a mechanical variation. Chinese has less SCD, Indian has less SCD, and you will say Bangladeshi has less SCD because you have no data to prove. Now, we have done a study. Then the concept comes of 1.5 prevention. That way, with EF, you should add something. Either you add an NSVT, you add a patient a pre-syncope, frequent VPCs, or ejection fraction is too low. So, probably these patients will be benefited more. We have done a study in our 145 eligible patients who meet the MEDI2 criteria. Classical MEDI2 criteria, and they are not a candidate of ICD, basically because they cannot afford it. We have followed for 2 years. And the primary endpoint was all-cause mortality. Now, when these patients are on optimal medications, more than 90% on beta blocker, 100% patient was on platelet inhibitors, more than 90% are on ACE inhibitor, statin is more than 90%. So, optimally treated patients, you cannot treat more than this. All patients are optimally treated patients. During follow-up period of 20 months, what is our mortality? 18% patient die. Out of 26 patients, majority of the patient die sudden cardiac death. 67% patient sudden cardiac death. And majority of these patients are only mild symptomatic, class 2 symptomatic. People say, I am coming with a train to show you, and in the train bathroom, the patient died. So, if you compare with MEDI2 population and our population, and only risk factor, the patient who are not given beta blocker, who are not revascularized, and creatinine is more, these patients are on multivariate analysis found to be significant. Nothing else found to be significant. Neither age, neither QRS duration, ejection fraction, presence of NSVT found to differentiate between survival and non-survival. So it is very, very, you compare with MEDIL population also. If we compare with MEDIL population, our population has higher hypertensive, higher diabetic, higher smoker. They are well treated, and though they are a higher mortality as MEDI2 population. So what we have concluded, the Indian population, though younger, less diabetic, hypertension less, smoker is less, treated well with the drugs, has similar total mortality as compared to patient in conventional R of MEDI2. So our population has a very high risk of sudden cardiac death when the MEDI2 population is compared. So we all demonstrate that only on basis of ejection fraction you can advise ICD. No other factors has shown to be any beneficial in differentiating patient who will be given device or who will be not given device. So any patient, this is a case of 50 years old male patient, he has anterior valmi 6 months back, post-primary PCI, LV ejection fraction 29%, no angina, no CHF, normal sinus rhythm, normal QRS, and NYHA1, no symptoms, on optimal medical therapy, no other comorbidity. Will you like to give the ICD or not? Yes. The literature says that these all patients required ICD to prevent sudden cardiac death. Other things, patient of hypertrophic cardiomyopathy, I think it has been very well described. There is a clear-cut guideline which patient required ICD in hypertrophic cardiomyopathy. All patients with SCD, VT, if there is a strong family history, if there are massive LVH, unexplained syncope, apocalyptic ejection fraction less than 50%, they all required ICD. It is class 1 or class 2 indication, both are equal. So SCM, there is a very clear-cut guideline. Sarcoidosis, it is very much prevalent in our society. In a sarcoidosis, if a patient is a VT of ejection fraction less than 35%, don't hesitate to give them ICD. Treat with steroid, but give ICD. We have seen a patient, people think, let us give an steroid and wait and watch, and 2 months after they have ICD. So these sarcoid patients, if they are a documented VTVF, if their ejection fraction is less than 35%, you treat with the steroid, but simultaneously give a device therapy in these patients. Patient with long QT syndrome. Never, because long QT syndrome is not an unusual finding in our population. If you find that patient has a long QT syndrome, there's a clear-cut indication on optimal beta blocker therapy, and you have tried the left ganglion blocker. If there's still a recurrence, then give ICD. In these patients, don't give ICD as a sole therapy, because when ICD will start firing, patient will have an anxiety, there may be a VT storm. So all long QT patients should never be given ICD alone. Mind it, never be given ICD alone. They should be on maximum dose of beta blocker, metoprolol 400 milligram, propanol up to 600, 800 milligram, and do the sympathectomy. So you should remember this thing. Short QT syndrome is a new entity. This short QT syndrome, if they have a survival of sudden cardiac death, give ICD to these patients. And this is what we are telling. This is a WPW with AF. And these patients are advised ICD. Absolutely no. WPWAF. And how can you diagnose? If there's a broad QRS and the QRS duration is changing and the RR interval is irregular, mind it, VT can never have a irregular RR interval. So if you are seeing an irregular RR interval, your QRS is broadening. Sometimes it is narrow, sometimes it is broad. It is absolutely one differential diagnosis, that is AF with WPW syndrome. So never give ICD, ablate, they will be fine. Again, ARVC. There are clear-cut guidelines. If you diagnose ARVC, if a patient has a syncope, patient has a VTVF, it's a class 1 indication for AICD. So these patients should be given. Brugada syndrome, yes. Brugada asymptomatic, I will not say, but Brugada syndrome with a maximum drug therapy, you should always advise ICD, because these patients with a short coupling interval, history of syncope, the CPVT is one entity when you should not give ICD as a first-line therapy, mind it. When you have given an optimal beta blocker therapy and still patient has a syncope, probably you should give it as a class 2 to class 2B indication, not class 1 indication. And this slide, I always hate this slide. People start telling in heart failure, now we have a plenty of drugs which has reduces the chances of sudden cardiac death. Believe me, no guideline says that if you have tried 3 months optimal doses, if your ejection fraction is still 35%, you should give ICD over and above the drug therapy. So please do not omit role of ICD, even in heart failure, ischemic cardiomyopathy patient whose LV function is 35% and who are all patients on optimal dose of problem. Just 2 slides. Just give me a 2 slides, this very important slide. I have calculated this magnitude of need of ICD in India and Bangladesh. You believe it? In India, this is a CSI data. 3 million MI every year. 30 lakhs MI every year. We all believe 30% will have ejection fraction less than 35%. This is a general problem. you required at least 13 lakh ICD implantation in India per year if all the class 1 patients are treated. I'm not talking of 2A, 2B. I'm not talking of channelopathy. It's only ischemic patient. But compared with Bangladesh population, you required 1,50,000 ICD in genuine indicated patients. And what is the implantation rate? See, in India, only 12,000 are being implanted. In Bangladesh, only 2,000 are implanted. So it's utmost need. Believe it, it is a very important thing. We should convince our government, we should convince industry, reduce the price, and the more so well, these are the problem. And these are the reason behind. Unawareness and lack of proper knowledge among doctors, lack of proper data of magnitude of problem, public education, lack of labs. But ICD, I always say, for PCI, you require more sophisticated lab because some of the primary PCI is an urgent procedure, but ICD may be elective procedure. So we should always think and insurance coverage for these patients. And in the last, I will always say, SCD is a worldwide problem. Out of cardiac arrest has a very poor prognosis. Many tools are emerging. It is a prime duty of physician, us, at least identify a high-risk patient and identify the cause and refer to appropriate cardiologists or any other person who are going to treat these patients. Optimal medical therapy is important, but ICD-based therapy should not be omitted in this patient, giving the clue that probably this patient will not die of sudden cardiac death. Thank you very much.
Thank you, sir, for your very informative presentation.